Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast podcast this week. We are at episode 32, if you can believe it. We're at the end of May, and you also may know what time of the month it is. It is Top 10 Tuesday, the last Tuesday of every month. We try to bring you my top 10 coding and billing and reimbursement questions that I get through my service called the On-Demand Coding Corner through my website. And I try to also give you the answers that I've had for, these clients. And hopefully if you're finding that you need unlimited coding questions through emails, you join the service. So if you're feeling comfortable with it and hopefully that give you some insight into what you're looking at. We've had very heavy orthopedic questions, some general practice questions. I think I had one cardiology, and I also think I had another pathology and skin code and a vascular code. So we've had quite a bit of activity this month. It's been a pretty busy month overall. Now, I know I said this about 6 weeks ago, but I am fighting a cough today and a cold. It's on a Sunday. I'm in my office recording. Hopefully to get through it, because we do try to be very consistent and drop every Tuesday, as you know. Unless I can't get my head off the pillow, that's what I'm doing. And it's funny because I know I've said this before, but I seriously am never sick, and in the last 6 weeks, twice. So I know my husband gave it back to me this time because he got sick from work because he's a teacher. But it's just interesting because as all the traveling I've done over 30 years in the industry and 20 years just being on the road so much, and I got sick maybe once every 5 years, and in the last 6 weeks it's just been settling just in my throat. So we're hoping to get through it. I might have to pause a little bit. Excuse me, there we go, to take a quick drink of my iced tea. If I don't know what I do without Starbucks, so there's a shout out to them. But I'm constantly drinking tea, and I was actually asking a friend of mine the other day. I said, so how much is too much tea where you're actually going to turn into a tea bag? And she's like, there's never too much. You just need to find different kinds. So shout out to Corinne there. She really kind of helped me with the tea thing, so I appreciate that. So what we're going to go on here is we're just really going to take a look again at the whole gamut of questions. Before we get started, though, as in every week, I want to first talk to our first sponsor and just say thank you, Medical Economics. Smarter business, better patient care. Follow them for the latest news and viewpoints on primary care, the business of medicine, and health IT. MedicalEconomics.com. So our first question comes from a Kansas City, Missouri client. And their question is, Terry, during an arthroscopic rotator cuff repair, the surgeon made an additional incision or portal site to repair the subscapularis tendon. How should this be reported? Well, the additional incision or portal site is not separately reported, believe it or not. It is considered an inclusive component of CPT because the code reads arthroscopy shoulder surgical with rotator cuff repair. And the code represents the repair of 1, 2, or even 3 tendons, and the number of portals made does not really alter the particular code. And so when another portal is required to repair maybe the subscapularis tendon, it is considered an inclusive component of the procedure. And so not only when you hear me give you some information with regard to questions and where the authoritative reference is, it's not just an opinion for me. I'm absolutely researching information through the societies for the different specialties that ask questions. And so in this case, it would be the American College of Orthopedic Surgeons, so AAOS. Medicare obviously is going to be number one for me. When Medicare says we can or can't do something, which is CMS, Centers for Medicare and Medicaid, we have to listen, especially if we've got a good percentage of our clients or of our patients that are Medicare patients. And we just don't want the federal government coming knocking on our doors saying, why did you do that? We want to feel comfortable that if they do come knocking and asking for information, we're saying this is why we did that, because it says to do it in CPT, because your policy says that, or because our society or association has put it out there that this is appropriate. So just wanted to kind of give you that preface first. From a Portland, Oregon client, another orthopedic question: how do I report a superior labrum from anterior to posterior slap lesion and capsule repair? So you can report 2 codes, the 29806 and the 29807, and those are arthroscopic codes. only if the SLAP lesion repair is type 2 or type 4, according to the AAOS Global Service Data Guidelines. That is, you must have two separate problems. So the capsular defect, not caused by the SLAP, which again is the superior labrum from anterior to posterior area, and a SLAP tear. So you have to have two separate areas. And documentation should also support the type of SLAP lesion being repaired. So when you look at those guidelines, make sure you're aware of that. Otherwise, that can sometimes lead to a little bit of a problem. From one of my Chicago clients, it says, Terry, what is the correct usage of CPT code 23420, which is the reconstruction of a complete shoulder rotator cuff avulsion, chronic, includes acromioplasty? Okay, so CPT code 23420, this is intended to identify an old tear. So remember, when you see chronic, this means, or this can mean, that it's been there a while, or it's an ongoing problem that is persistently getting worse, or it's something that isn't a fresh injury. The type of extreme tear usually requires rearrangement of the normal anatomy and sometimes grafting with other biological or non-biological material for repair. So according to the CPT Assistant, October 2005, Volume 15, Issue 10, pages 23 and 24, it also states not only that specific wording, but AAOS also chimes in and says if there is a significant retraction with a large tear, extensive releases and mobilization may be required, justifying the use of that 23420 code. If the fascia, which again is the autologous connective tissue taken from the patient, or synthetic material is required, the CPT code 23420 is also appropriate. If tendon transfer is appropriate. If tendon transfer was performed, then you get to also add the code 23397 with a 59 in addition to the 23420 code. So we always want to make sure that when you're looking at some of these services, that you can really kind of visualize what's going on with that. And so I try to give you not just references from the AAOS when I'm talking orthopedic, but also really talking about CPT, which is, we know the current procedural terminology, and the CPT Assistant is really their rules on how to do things when the CPT book itself doesn't give the complete information in the descriptor. So it means that you're basically trying to figure out, okay, well, this code is descripted this way, but how do I use it? And so it's really nice to be able to get that CPT Assistant. I used to have a really hard time with it as far as what it was, because one of the things that the CPT Assistant does is it also pulls out mistakes in the CPT code book. And so the AMA puts out this publication that we don't have a choice. We have to use. And then when they make a mistake, they ask us to pay for another publication to find the mistake. Now, they do put out an errata, but unless you know exactly what the code is or why it was a mistake or anything like that, sometimes it's hard to find. But now it's just, I do a lot of appeals and collections and revenue cycle management, which that's kind of the new word for it. So I actually love having the CPT Assistant because I can pull that information right out and say, this is why this is to be reimbursed this way. Number 4, same client in Illinois. They say in rotator cuff reconstructions, there must be major muscles torn or avulsed to use the 23420, correct? So note that the official descriptor of the CPT code 23420, reconstruction of complete shoulder rotator cuff avulsion, chronic, includes acromioplasty. This means that you can have a cuff avulsion where the supraspinatus and the infraspinatus muscles are torn so severely that reconstruction is necessary to bring the cuff back up to anatomic location. Since shoulder injuries and rotator cuff tears can vary from patient to patient, the orthopedic surgeon needs to document the extent of the injury and if it is a repair rather than a reconstruction. So a reconstruction would involve more than just anchors and tacks. A repair is typical for a shoulder that has a tear less than 5 centimeters and are in effect repairable. So usually those small tears, they're more traumatic, or I should say they're more acute than things that have been going on over time. Repair in the reconstruction is saved for patients where they have a massive tear. Usually the norm is larger than 5 centimeters and are considered irreparable, and they also come with greater risks though, because the successful outcomes are not always there. So although rotator cuff tears can be repaired with excellent results, the chronic massive tears of the rotator cuff are continuing to be a problem to treat. So these are what is also described as what they call irreparable rotator cuff tears, because the torn tendon cannot reach to the original footprint of the area, and so this is due to the tendon retraction with elasticity. So there's muscle atrophy, fatty infiltration, usually around the humerus area. So currently there are limited options for patients with irreparable rotator cuff tears, but prolonged conservative treatment can also have negative effects and lead to further degeneration of the rotator cuff patch. So patch graft surgery sometimes is carried out in addition. Sometimes also, because of the high re-tear rate, according to AAOS, a reverse total shoulder, and we call those an arthroplasty, is also an option, but this can be high risk and basically because it leaves no further options if it fails, and not to mention the fact that it's a major procedure for younger patients. So you are in effect replacing the damaged parts of the shoulder and replacing them with artificial components that you hope work. And so I'm not saying that these haven't been successful. It's just that doctors really have to make some judgment calls here for older and younger patients. And some of you, when you think of older patients, I'm sure you're thinking, okay, well, an older patient is Medicare age. Not so fast. Basically, an older patient is over 35 when it comes to joint injuries. So if you're 35 or older, well, they actually give you some grace. They're over 35. So I'm going to say if you're 36 or older, that's considered where that you could now be in that chronic state or possibly benefit more from the total shoulder, reverse shoulder, than just from a simple repair or hopefully an arthroscopic repair. Because once you get into reconstruction and some of that, you're really you're changing again the footprint or your whole anatomical makeup there, and so your body's still not coming into its own, as that's why we try not to do that with children, with adolescents, and with people in their 20s, because your body's still trying to figure out its elasticity. You're still trying to figure out how you move, things you do. And I would think that people between 25 or between 20, let's go back a little bit, and 35 are highly active as compared to people that be over 35. And just your activity tends to change too. When you're over 35, you're more playing with your kids and throwing a football around than you're out there actually playing football. Now, of course, shout out to those people that are still playing and active in sports like that, as somebody who actually plays with a team. But just this is how they figured things out from a clinical perspective on what's chronic versus what is acute. And I know I kept going on with that question. Mostly it was just a coding question. But if you could not tell, I love coding. It's the reason I wanted to create the CodeCast podcast. It's just a puzzle to me. I love puzzles. And, why we can and can't do this a certain way, why this or this doesn't make sense. And then just mixing clinical and revenues and discussions within that. And this is Disneyland for me. So I know you're probably thinking, Terry, you need to get out more. But honestly, when they say, do what you love and it'll never be work, this isn't work for me. I look forward to doing these every week. And yes, it's a grind a little bit, only because I feel like I always want to have at least one or two available, and make sure that I don't miss my deadlines. But there are days when it's just things click and you're doing good things, and hopefully you're getting better at your profession and getting some gems here. And so when I feel like I'm doing that for you, that's a good feeling for me. So before you think I'm just getting too squishy today, let's just move on from that and take a minute and thank our sponsors. The CodeCast podcast is also brought to you by ICD-10monitor.com, helping healthcare providers make informed decisions as they implement the ICD-10 coding system. You can also join #Talk10 Tuesdays live at 10 a.m. Eastern for all things ICD-10 every Tuesday. And Orion Healthcare, their purpose is to revolutionize global healthcare so every individual receives the perfect care for them. Join the revolution, orionhealth.com since 1993. So question 5 comes from a client in Orlando, Florida. And it looks like they're back to an E&M question. So our electronic medical record populates the past family social history field for every visit on a patient from a previous visit. So it sounds like it brings it forward. So Terry, our question to you is, does that count as an element? And if we ask the patient how their vacation was, does that count as a social history component? It's funny you ask that, as I'm doing audits, as I keep mentioning each week. So if it's brought forward and the information hasn't changed, there's two trains of thought there. And basically, it could be considered a clone note. You really need to revisit it, at least if you're going to be in that level 4, level 5 established patient visit, because you can't just say I'm repopulating a field and then move forward with it. So I would recommend that you at least revisit the past medical social history. And if, you need 2 elements to get it to a level 4, and you need 3 to get to a level 5. So on an established. So if you are revisiting the medicine and reconciling medications and asking the question, how's the family doing in case there's any clinical issues, then that's okay. The question came up about asking the patient how their vacation was. As long as it's in relationship to their condition, then yes, I would think that's fine. So, Mary, how was your trip to Europe? Did you have any problems walking around town? Did your, osteoarthritic knee, did that hinder you at all? Did you find any pain or swelling, or how was that? Just asking the patient how was Europe, I would frown on that. I'd want to find it some kind of a direct or indirect way that it's tied to their condition. So let's not try to be too, I don't want to say lackadaisical or lazy about it, but let's try to keep our eye on the ball and realize people are looking at your documentation. It's an audit form. It's an audit tool. It's something that at some point somebody could say, let me look at it. And so you always want to be above reproach there. Number 6 is from a New Jersey client. It says, Terry, the physician entered atrial fibrillation stable into the patient encounter as one of the chronic conditions. You had mentioned that we need 3 chronic conditions and the status of a chronic condition to be able to code that as a chief complaint. Can you elaborate on that and let us know what the components are for the history of present illness? Okay, so atrial fibrillation is an irregular and often rapid heart rate that can increase the risk of the patient of stroke, heart failure, and other heart-related complications. So during atrial fibrillation, and follow me with this so then you can see how I'm picking out my HPI elements, my history of present illness. So during atrial fibrillation, the heart's 2 upper chambers, the atria, beat chaotically and irregularly out of coordination with the 2 lower chambers, the ventricles of the heart. So atrial fibrillation symptoms often include heart palpitations, shortness of breath, and weakness. Okay, so here we are. So if this is documented as one of the 3 chronic conditions needed to support an extended HPI or chief complaint, it is allowed. The HPI element would first be location, because we know we're in the heart. And then the second one would be quality, how it looks, acts, or feels, because now we are talking about the fibrillation part, the heart beating chaotically, what it actually is. So you would actually have 2 elements unless the physician also added as additional sign or symptoms, such as what I mentioned, the palpitations or shortness of breath. So hopefully that helps. You've got 2 there, which means that you would be at a limited. Number 7 comes from a client in Houston, Texas. My practice employs both physicians as well as non-physician practitioners, MPPs. We've had some issues recently where our claims from patient encounters with mid-levels are getting denied from certain payers. What are we doing wrong? Okay, so if the payer is United Healthcare, I don't know if you've noticed this, but you may have noticed within the last 6 months, you're probably having issues getting paid with claims. All claims for E&M services dated on or before September 1st of 2017 for that payer require an SA modifier. So S is in Sam, A is in Apple. Whenever there's a nurse practitioner rendering services in collaboration with a physician, that's the descriptor. But what they put in United Healthcare's June 2007 network bulletin is they said when these services are provided by an NP, nurse practitioner, an APN, advanced practical nurse, a PA, or a clinical nurse specialist, that same SA modifier is supposed to be used. So the one thing that's tough about this is that if every insurer is going to start to require their own internal or their own set of identifying modifiers, it's going to get pretty confusing for offices, because most CPT and Medicare modifiers are pretty well known to billing professionals. And so I would monitor that closely and check each payer, because they have different rules for reimbursement for different providers. So make sure you check with each individual insurer if you're finding that you're having issues getting paid for extenders, but especially with that particular modifier, because some of the other payers I'm noticing are considering it. Number 8 comes from a New York client. Terry, my practice is moving to a different location, and the staff is in the process of purging old patient records off of the mainframe computer. What is the best and legal way to dispose of records where the patient is no longer living or no longer part of our practice? Okay, so I'm not an attorney and I don't pretend to play one on TV, so I am, however, a healthcare professional that does have the rules and regulations that's put out from the Health and Human Services Office for Civil Rights website, and that's at hhs.gov. So you can also read about this, but just so in case you're having trouble finding it, it's really buried, usually on page 150, somewhere around there. But it says anyone who is charged with disposing protected health information, that's called PHI, that's the acronym, must be trained, including volunteers. There are a few different options, as the privacy and security rules do not specify a particular disposal method. However, covered entities cannot dispose of PHI, again, patient or protected health information, in dumpsters or other places where the public or other unauthorized persons can get to it. So these are just two things in general that I just want to make sure before you go ahead and research this out specifically, because you want to have the document for your physicians. But this is at hhs.gov. So it says in general, examples of possible or proper disposal methods may include but are not limited to: for PHI and paper records, shredding, burning, pulping, or pulverizing the record so that PHI is rendered essentially unreadable, indecipherable, and otherwise cannot be reconstructed. Okay, that you can't. Every word they used to be able to destroy the record was used. For PHI electronic media, clearing using software or hardware products to overwrite media with non-sensitive data, purging, degaussing or exposing the media to a strong magnetic field in order to disrupt the recorded magnetic domains, or destroying media, disintegration, pulverization, melting, incinerating, or shredding. So I think you get the drift. Basically, they're saying you need to destroy it beyond all repair. And I would love to use a movie acronym a long time ago, but it's not PG-13 rated. So, but it's basically beyond all recognition. You need to get rid of it. So that's really what they're going for there. So just make sure you're not just throwing them in dumpsters. There was a huge issue with Office of Inspector General on this, and HIPAA police, I like to call them, also came out and went, "What are you doing?" Okay, so from a California client, number 9, this one's pretty quick. What is the code for right upper extremity venogram? I'm getting confused with 75820 and 75860. The answer is the 75820 unilateral upper extremity venography. The 75860 says jugular catheter, and it's through the thorax area. So it's in the general area of the upper extremities, but it's through the catheter as described in the code. The 75820 is basically the upper extremity venography unilateral. Okay, so here's one, and this one is interesting because this one is talking about, we're looking at ICD-10 codes, but we're really looking at skin and derm. And so this one says, Terry, a patient undergoes outpatient surgery. A skin lesion of the cheek is surgically removed and submitted to the pathologist for analysis. The surgeon writes on the pathology order, skin lesion. The pathology report comes back with a diagnosis of basal cell carcinoma. A laboratory billing consultant is recommending to us that the ordering physician's diagnosis be reported instead of the final diagnosis obtained by the pathologist. Also, an insurance carrier is also suggesting the case to be coded as skin lesion, since the surgeon did not know the nature of the lesion at the time the tissue was sent to pathology. Which code should the pathologist use to report in this claim? Okay, so you're talking about the pathologist. By the way, a pathologist is a physician, and if the diagnosis is made, it can be coded. It's appropriate for the pathologist to code what is known at the time of the code assignment. So, for example, if the pathologist has made a diagnosis of basal cell carcinoma, as it shows here, assign the code C44.319, basal cell carcinoma of skin or other parts of face. If the pathologist had not come up with a definitive diagnosis, it would be appropriate to code the reason why the specimen was submitted, In this instance, then you'd go back to the skin lesion of the cheek. Okay, so the coding clinic, which are the official guidelines for reporting diagnostic outpatient services, Section 4, letter K, as in kangaroo, state for outpatient encounters for diagnostic tests that have been interpreted by a physician, pathologist, and the final report is available at the time of coding. Code any confirmed or definitive diagnosis or diagnoses documented in the interpretation. In that statement right there, this was a diagnostic test pathology that was interpreted by a physician pathologist with a confirmed diagnosis in the final report, basal cell carcinoma, being available at the time of the coding that needed to be reported. So this reinforces the fact that it's ethical to follow the coding guidelines, no matter the years of experience one or what position they're holding. And that is our last question for the day for our Top 10 Tuesday CodeCast. But I would like to thank our last sponsor, Better Living. Since 2002, Better Living has been the premier digital lifestyle brand dedicated to travel, food, health, home, and more on betterliving.com. So before we end, I had a fun announcement that came out this week. A couple of things. First of all, and for those of you that follow me on Twitter at TerryCoder1, I appreciate that. You can also go to my Instagram account at TerryNCA. But because I posted something that was just very humbling for me, getting a couple of award announcements for Coder of the Year and Innovator of the Year since I started doing some things with designing waiting rooms. But here's a fun announcement for our podcast. So the podcast has been nominated, the CodeCast podcast, for a People's Choice Award for excellence in 2 categories. One is business, and the other one is health informatics. So voting by our listeners will open up July 1st at podcastawards.com. So that's kind of exciting for me. I didn't actually really know they even had awards for podcasters, but I guess that would make sense. So this is just a cool acknowledgement of the work that we put in here. It takes my show's producer, who always makes me look good. He puts it in, he gets it there every Tuesday, and he does my beginning script or edits for me, so it sounds good. My music producer and content collaborator, DeSasson Johnson, he always makes sure that I sound good, I look good as well, and that the music fits and that my topics are of interest. So shout out to both of those guys. I love them to pieces because they really help me do what I need to do. So now with over 8,000 listeners, not only in the United States but also abroad, apparently we're very big in Germany, we really appreciate all of you and hope you will vote for us in July. And it would be cool to be the award-winning CodeCast podcast. So for more details on the opening up the voting, I'll let you know because it does start July 1st, later this summer. And we also may be taking our CodeCast podcast to YouTube. So I've been asked by several people if I could do that so they could subscribe. And we've had a lot of requests for that. So look for that. I think Joe said he's going to be doing that pretty soon. So I hope everyone is enjoying the warm weather. And as we head out of May, and hopefully you have some fun outdoor plans ahead. I actually have a cornhole tournament that I'm in part of, and I'm going to be doing a 2K walk as well. So I've got some things outside that are going to be pretty fun for me. Our June episode will be taking a little bit of a left turn. I really want to speak to healthcare professionals on a personal level and just talk to you a little bit about what you can do just to take a little bit of a step back, because we all need it a little bit. So join us next week for a fun topic. And everybody, make it a great day.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer DeSasson Music.